Welcome back. Now we turn to reporting medical information. Essentially, the patient report you provide either over the radio to the hospital during transport or in preparation for your handoff. This is where you convey the patient's details to ensure the next level of care, the ER team, is prepared. Think of it as giving the hospital a snapshot of the patient and what you've done so far. The slide lists key elements that medical information should include. Let's go through each of these critical items and expand on them. Destination facility and ETA. Always state where you are taking the patient and how long until you get there. For example, we are transporting to County General Hospital, ETA 5 minutes. This lets the hospital know to expect you and how much time they have to prepare. It's especially important in serious cases. If you alert them early, they might ready a trauma room or cardiac team. Many systems use this as the first part of a radio report, like County General Ambulance 3 is 10 minutes out with patient info. Keeping the hospital updated on your ETA helps them allocate resources appropriately. Provide the patient's age and gender as basic identifying information. Age and sex often influence medical decisions. A 5-year-old with chest pain is very different from a 75-year-old with chest pain. For example, certain conditions are more common in certain age groups or sexes, and treatments, like medication dosages, vary with age. Stating this up front, 72-year-old male or 16-year-old female, frames the context for the listeners. The chief complaint. This is the primary issue or symptom that prompted the 911 call. Essentially, what is most wrong right now? It could be a medical complaint like severe chest pain or difficulty breathing or an injury, gunshot wound to the abdomen, or broken left femur. The chief complaint should be summarized in a few words. This immediately tells the hospital what the main focus is. Think of it as the headline of the story. For example, 52-year-old female chief complaint, sudden onset severe abdominal pain. That grabs attention to the big problem. Give a short description of how the chief complaint came about, including any important events leading up to it. This is often 1 or 2 sentences describing the mechanism of injury for trauma or the timeline of symptoms for a medical issue. Include only the relevant details. For instance, for a trauma, patient fell approximately 15 feet from a ladder onto concrete, landing on his side. For an illness, chest pain began while jogging, lasted 10 minutes at home before 911 was called, pain is constant, and 8 out of 10 now. This information provides context. It helps ED staff anticipate possible injuries or causes. A 15-foot fall suggests possible internal injuries. Chest pain after exertion suggests a cardiac event. Keep it focused. The hospital doesn't need the patient's entire medical saga, just the story of what's happening now and important background leading to it. Medications and allergies. Report any medications the patient is currently taking, especially those relevant to the situation, and any known allergies, particularly drug allergies. Medications can clue hospital staff into medical history, like if the patient is on insulin, they likely have diabetes, on nitroglycerin, or a beta blocker, likely heart disease. Also, knowing what's been taken can prevent drug interactions. For example, if the patient already took their own nitroglycerin or EpiPen before you arrived, mention that. Allergies are absolutely crucial. If the patient is allergic to penicillin or aspirin, etc., the hospital must know to avoid those. Failing to mention a severe allergy could put the patient at risk of getting a contraindicated medication. A quick way is to say medications, list, allergies, list, or no known drug allergies. For example, medications, metoprolol and Lipitor, allergies, penicillin, causes rash. This alerts the hospital to avoid penicillin-class drugs. Remember, omitting such information can have serious, even fatal repercussions. So if you only have time for a brief report, always squeeze in critical allergies. Other pertinent medical history. Here you mention significant past medical history that relates to the current problem. This could be chronic conditions or past surgeries. For a trauma patient, something like the patient is on blood thinners for a history of stroke is very pertinent because bleeding risk is higher. For a medical patient, mention conditions like diabetes, heart disease, asthma, seizures, etc., if relevant. For example, history of hypertension and a prior heart attack in 2018. For a chest pain call, or history of epilepsy, last seizure 6 months ago for an active seizure call. This helps the hospital tailor their approach. You don't need to list every ailment the patient has ever had, just the ones that matter now. If the patient has no significant history, you can say no other history or otherwise healthy to keep it brief. In our earlier chest pain example, reporting the prior heart attack and hypertension tells the ED this could well be cardiac related. Patient's level of consciousness and level of distress. Describe the patient's mental status, alertness, orientation, and how sick or injured they appear. Are they alert and talking? Confused? Unconscious? And are they in mild, moderate, or severe distress? For example, patient is awake, alert, and oriented, but in obvious pain, or patient is unconscious with shallow breathing, or alert and anxious, struggling to breathe. If the patient's level of consciousness has changed during your care, like they were unconscious but are now responsive after treatment, note that too. This gives a quick sense of how critical the patient is. A patient in no apparent distress is likely stable. One in severe respiratory distress, unable to speak full sentences, is critical. Including a brief vital sign snapshot here can be useful if something is notably abnormal. BP 80 over 50, very weak pulse. That underscores a critical situation. While the slide phrase is level of consciousness distress, in practice, you might also mention vital signs or critical exam findings in the same breath, since they reflect distress. For example, he is conscious but very lethargic. Blood pressure is low at 80 over 50. Remember to keep it pertinent. Focus on the abnormalities. You don't need to recite every vital sign if most are normal, except the blood pressure is low. Highlight the low BP. The goal is to convey how the patient is doing right now in a concise way. Treatments given and patient response. Although not explicitly on the slide text, it's standard to inform the hospital of what interventions you have performed and how the patient responded. This prevents duplication of efforts and lets the hospital anticipate next steps. For instance, if you gave nitroglycerin to the chest pain patient, say so and report the effect. Chest pain reduced from 8 out of 10 to 4 out of 10 after 1 nitro. If you immobilize the patient on a backboard or controlled bleeding with a tourniquet, mention that. Example: we've placed the patient on high-flow O2 and started an IV. We also administered 324 milligrams aspirin and 1 nitroglycerin. His blood pressure remained stable at 130 over 80 after nitro and pain went from 9 to 6 out of onunku. If nothing has changed or the patient didn't respond to a treatment, you can say that too. No improvement after epinephrine. Including treatments and responses completes the picture for the receiving team. It tells them what's been tried and what has or hasn't worked, so they don't repeat something unnecessarily, or they know to prepare for next steps. For example, if you gave maximal nitro for chest pain with no relief, the hospital might prepare for a more aggressive intervention. If you're short on time in a radio report, at least mention the most significant treatment like 12 lead ECG transmitted or epi given for allergic reaction. In person, you'll give a fuller account, but on radio we prioritize the highlights due to time. Now, delivering all that information smoothly is an art. You want to be concise yet cover all the bases. A good radio report might only last 30 seconds or so, covering the bullet points we discussed. In an in-person handoff, you have a bit more time to elaborate on details as needed, but it's wise to keep a similar structure so nothing is forgotten. Many EMS professionals use memory aids or acronyms to ensure they hit every point. Find a system that works for you and practice it. Example of an effective radio report. Saint. Mary's Hospital, this is Ambulance 12. We're about 5 minutes out. We have a 67-year-old male patient, chief complaint of chest pain. He has a history of heart attack and diabetes. The pain started about 30 minutes ago while he was resting, and it's been 8 out of 10 in intensity, unrelieved so far. He's alert, very anxious. Skin is pale and sweaty. Blood pressure 90 over 60, pulse 120, respirations 24. We've given 4 baby aspirins and 1 nitroglycerin. Pain remains 8 out of 10. We have him on O2. ETA 5 minutes. In this report, notice how almost every element from the list is covered. Destination, ETA, age, sex, chief complaint, chest pain, history, prior MI, diabetes, brief history of present illness, started 30 minutes at rest, still 8 out of 10, meds given, aspirin, nitro, and patient response, pain unchanged, BP 90 over 60 after nitro, which is a bit low but still okay, current condition, pale, sweaty, anxious, implying distress, vitals given, and it fits in roughly half a minute. This equips the hospital to prepare. They know it's likely a serious cardiac event. They might call a cardiologist or prep a cath lab, and they'll be ready with IV, monitor, etc. An example of a poor report. Hey, we're coming in with a guy who fell off a roof. He's an older man. He was checking his roof after a storm, and yeah, he fell down. There was a lot of blood where he fell. His wife says he's stubborn. Anyway, we got him on a backboard. We'll be there in, I don't know, soon. This report is problematic. It fails to mention the patient's vital signs, level of consciousness, specific injuries, or how far he fell. It includes irrelevant or unprofessional remarks, he's stubborn, or details about why he was on the roof. It doesn't give an ETA or age. The hospital hearing this would have more questions than answers. How badly is he hurt? Is he conscious? What is a lot of blood? From where? How soon is soon? It also sounds unprofessional. The tone is casual and disorganized. As a result, the hospital might not mobilize trauma resources that they actually need, or they might be expecting something less serious than it is. This kind of communication can reflect poorly on the EMS crew's competence. In short, avoid extraneous details and focus on pertinent information. As one EMS communication expert put it, spending time on irrelevant information can hinder everyone involved. A focused, relevant report not only ensures the patient gets appropriate care, but it also demonstrates your professionalism and builds trust with the receiving facility. After giving your report, listen for any questions or orders from the hospital. Sometimes on the radio, the ER might ask a follow up, like, "What's the patient's oxygen saturation?" Or, "Did you say the patient is on a blood thinner?" Answer briefly and clearly. If the hospital wants you to do something en route, rare, but they might say, "Go ahead and start a second IV" or similar, acknowledge and follow through. One more crucial point: never omit critical information intentionally just to be brief. If you are short on time, say the ER is already in sight when you finish the main report, at least mention the most life important data, like major allergies or interventions, either in that report or as soon as you arrive. Important details left out can lead to patient harm. For example, failing to mention a patient's do not resuscitate DNR status or a crucial medication allergy during your report could lead the hospital team to take actions the patient or their health can't tolerate. If you realize you forgot something important in your initial radio call, you can radio again with a quick update, or make sure to emphasize it in your verbal handoff upon arrival. Omitting information can have fatal repercussions, so we strive to communicate a complete picture. To summarize this slide, when reporting medical information, include all the key patient data: who they are, what's wrong, what happened, what you found, what you did, and how they're doing now. Do it in a concise, organized way. This ensures the receiving healthcare professionals have everything they need to continue care effectively. A well structured report not only facilitates patient care, but also reflects well on you as a competent provider, fostering a good working relationship between EMS and hospital staff. Once you arrive at the hospital, communication isn't over. You still need to hand off the patient in person. Let's talk about professional communication with other healthcare providers during that handoff. The final step is communicating with other healthcare professionals, primarily during the in person handoff at the hospital. This is where you transition the patient's care to the ER team, nurses, doctors, and also ensure all necessary information is transferred. Professional communication at this stage is critical for patient safety. The slide highlights a few points. Give an in person report with info not given on radio, be mindful of privacy, answer all questions, and provide written documentation. Let's break those down. In person report: share information not given on the radio. Once you arrive at the hospital, you and your partner will physically transfer the patient to a hospital bed and then give a verbal report to the receiving nurse or physician. This report should include all the pertinent information about the patient. If you already gave a radio report, think of that as a preview. Now you'll give the complete story with any additional details. For example, over the radio, you likely did not include the patient's name for privacy reasons, but in person, you should provide their name and age so the hospital can identify them and start their records. You will reiterate the chief complaint, vital signs, treatments given, etc., even if stated earlier, and add any new developments that occurred since the radio call. Also share details that might not have been appropriate for radio. For instance, a very detailed medical history or sensitive personal information that you wouldn't broadcast. Essentially, don't assume the hospital knows anything that you haven't explicitly told them. It's better to repeat information than to leave something out. One helpful approach is to structure your handoff similarly to your radio report, but then expand. This is John Doe, 67-year-old male with chest pain. To recap, pain started about 30 minutes prior to our arrival while he was at rest. History of heart attack in 2018, hypertension, and diabetes. Meds include metoprolol, lisinopril, insulin. Allergies, penicillin. On our arrival, he was alert, very diaphoretic, BP 90/60. We gave aspirin and a nitroglycerin with no relief. Pain remained 8 out of 10. BP dropped to 85/60/58 after nitro. We have IV access, oxygen on. Last BP en route was 88/60, heart rate 118, sinus talk on the monitor. He's still having pain, no other complaints. Name is John Doe, and here's his medication list we found in his wallet. Do you have any questions? This kind of report covers everything relevant and ensures the hospital team is fully informed. It's also good to mention anything you wanted to do but couldn't, or any concerns you have, like, "We didn't give a second nitro because the blood pressure was too low," or "We couldn't get a second IV, he has very poor veins." This helps the hospital understand the context and pick up where you left off. Be mindful of who can hear you, privacy and professionalism. Hospitals are busy places, and during your handoff conversation, other people might be nearby. Other patients on stretchers in the hallway, visitors, or additional staff not involved in this case. It's important to protect the patient's privacy, per HIPAA and basic respect. Don't shout sensitive details. Ideally, give your report in a somewhat private space, like a dedicated trauma room or the patient's bay in the ER. If you find yourself giving a report in a hallway or a semi public area, be conscious of your volume and language. For example, you wouldn't want to announce details like the patient has a history of HIV or she had a miscarriage last year loudly for bystanders to overhear. Those details should be communicated discreetly to the nurse or doctor directly. Also, consider the patient's dignity. If the patient or family is within earshot, which they usually are, speak about the patient respectfully and reassuringly, even when talking to the other providers. Avoid using jargon or crude terms that the patient might misinterpret. For instance, instead of saying she's postictal and was flopping like a fish out of water, which is unprofessional and could upset the family, you'd say she's post seizure right now. The seizure activity has stopped and she's in a drowsy recovery phase. Being mindful of your audience also means watch your nonverbal behavior. No eye rolling or negative remarks about the patient, even if it's a case of, say, a frequent 911 caller or someone who made a questionable decision leading to injury. Those kinds of reactions can damage the patient's trust and are not appropriate in front of hospital staff either. Essentially, keep it professional and confidential. If discussing something sensitive, you might pull the nurse aside or speak in a lower voice. Hospitals also appreciate when EMS doesn't alarm other patients or visitors. For example, if family members are present, don't deliver grim information in a blunt way in front of everyone. You might ask the nurse or doctor if sensitive news should be discussed in private. In summary, share information in an environment and manner that respects the patient's privacy and feelings. Answer all questions. After your initial handoff report, the ED nurse or physician will often have follow-up questions. They might ask things like, what were the exact vital signs, if they want to double-check trends? Did he take any aspirin before you arrived? Or when was her last meal, etc. Be prepared to answer these as best you can. This is not the time to rush off or get defensive. Even if you feel you already answered something in your monologue, be patient and answer again. The ER is double confirming because it's important for them. If you don't know the answer, for example, maybe you never got to ask when the patient last ate, or you didn't measure a temperature in the field, it's perfectly okay to say, I'm not sure, we didn't obtain that, or no, we did not check her blood sugar because it was a trauma and she had no diabetic history, but we can do one now if you'd like, etc. Offering to help with anything you missed shows teamwork. Sometimes in the heat of the moment, EMS might forget to collect a piece of info. If the hospital asks and you realize you have it in your notes, provide it. If you realize you don't, you might quickly ask the family right then if they're present. Excuse me, do you know if she took any insulin today? To get the answer for the team. The main point is to remain engaged in the conversation until the receiving team has no further questions and explicitly takes over care. One way to prompt is after your report, you can ask, what questions can I answer for you? Or, is there anything else you need to know? This opens the door for the nurse, doctor, to voice any concerns. Avoid the temptation to drop the patient off and leave immediately. Leaving unanswered questions can lead to missing information, which could harm the patient. For example, if the ED staff doesn't catch that the patient received a certain drug en route because it wasn't communicated or they didn't ask, they might accidentally give it again. So thorough Q&A at handoff is a safeguard. It's also a sign of respect. You're not just dumping the patient and running, you're collaborating in their care transition. Interagency communication extends here as well. If you're handing a patient to, say, an air ambulance crew or another EMS unit for an intercept or transfer, the same rule applies. Give them a full briefing and answer their questions. This ensures continuity of care across teams. Provide written documentation. Once your verbal report and any immediate patient care tasks are done, make sure the hospital staff receives your written patient care report or a copy of it if your policy requires you to finish it later. Many EMS systems have electronic tablets or forms. If you can't complete it right then, often a short transfer form or drop sheet with key info is left. This documentation typically includes vital signs, the timeline of interventions, medications given with doses and times, and patient history details. It serves as a permanent record that the hospital can refer to after you leave. Why is this so important? Because memories fade and details can be overlooked in a busy ER. The written report backs up what you said and often contains additional nuances, like serial vital signs, ECG printouts, etc. Studies have shown that incomplete handoff information is a common issue. For instance, research noted that in many EMS handoffs, less than half included an overall assessment or all pertinent exam findings. If some detail slips the verbal report, it should be in writing. The hospital will include your report in the patient's medical record, which helps the next providers, like hospital specialists, understand the pre hospital scenario. Also, from a legal and quality standpoint, your documentation is critical. It's evidence of what care was provided and what information was exchanged. Omitting key information from the written report can be as bad as not saying it at all, since later shifts or providers might only have that document to go on. EMTs are responsible for writing reports that inform the decisions of doctors and nurses, and missing information can lead to serious mistakes. For example, if your written report forgot to mention the patient got 4 milligrams of morphine in the ambulance, the hospital might give additional pain meds too soon, not realizing the total dose, potentially causing an overdose. So, ensure that everything you did and observed is documented clearly. In some cases, you might physically give a copy to the nurse before you depart, or you might finish it back at station and then it's available electronically to the hospital. Regardless, make sure the information gets to them. If you have any handwritten notes, like a list of medications you copied down at the scene or a ECG strip, hand those over as well or attach them to your report. A comprehensive handoff includes verbal exchange and the written report. Let's consider a quick scenario highlighting the importance of good handoff communication. Poor handoff. Example, paramedics arrive at the ER with a trauma patient from a car accident. They rush the patient to the trauma bay, give a very cursory report. This is a 25-year-old male, car crash. We gave some fluids, here he is, and then quickly leave to respond to another call. They are in a hurry and forget to mention that the patient was found to have a possible penicillin allergy from his medic alert bracelet and that they gave 2 milligrams of morphine for pain. They also haven't handed over a written report yet. The trauma team is left trying to piece together info from the patient, who is groggy, and a bystander. In the chaos, the allergy info isn't conveyed. A doctor later orders a dose of a penicillin class antibiotic as infection prophylaxis, and the patient suffers an allergic reaction in the ER. Additionally, the nurse wasn't sure if any pain meds were given pre-hospital, so they administer morphine, resulting in the patient getting more than intended. These complications could have been avoided with a thorough handoff where all details were shared. Good handoff. Example, now imagine the paramedics take an extra minute to deliver a full report. 25-year-old male, unrestrained driver in a T-bone MVC, impact on driver side. Approximately 10-minute extrication, initial assessment. GCS 14, slightly confused. Vitals stable. Blood pressure 130/80, heart rate 100. He had a brief loss of consciousness at scene per witnesses, but was awake upon our arrival. We placed C-collar and backboard, started 1 IV and gave 500 milliliter fluids en route, also gave 2 milligrams morphine IV for pain. 5 minutes ago, he reported pain 7 out of 10 in his left flank, now down to 4 out of 10. No other meds given. He has a medic alert bracelet indicating penicillin allergy. Last vital signs, BP 120/78, HR 98, SPO 299% on 15 liters O2. Here is his med list from the wallet, hands card. Looks like just allergy meds. Do you have any questions? The ER team asks a couple clarifying questions, like any chest pain? How long was he trapped? Which the medics answer. They hand over their written report with all details. The nurse and doctor are now well informed. They know about the allergy and will choose a different antibiotic. They know how much pain medication was given and can adjust their dosing, and they have a good sense of the mechanism of injury to guide their exam. They will pay attention to that left flank for internal injury. The patient's care continues seamlessly, and the EMS team departs after ensuring nothing else is needed. This is how a professional handoff should go. Finally, remember that communication with healthcare professionals is a two-way collaboration. At the hospital, you might also receive feedback or additional information. For example, a doctor might tell you their findings or say, "Good job on getting that IV." A nurse might clarify something that will help you on future calls. By the way, the patient's family mentioned he has a DNR. Keep an eye out for his bracelet next time. Be open to learning in these moments. It can improve your future practice. Interagency communication isn't limited to just giving info. It's about working together with the same goal, the patient's well-being. To wrap up, clear, professional, and complete communication at handoff ensures the patient gets seamless care and nothing falls through the cracks. You share all relevant info verbally, respect patient privacy while doing so, answer questions to fill in any gaps, and leave thorough documentation. By doing this, you uphold the high standard of care as the patient moves from the pre-hospital setting into the hospital. In conclusion, mastering professional communications in EMS, from the first radio call to the final handoff, is essential for quality patient care. We've seen that small communication failures, a missed address, an unclear order, an omitted allergy can snowball into serious consequences, while good communication practices, like confirming information using plain language, showing cultural sensitivity, and being thorough in reports, improve outcomes and safety. Studies and experiences continually show that better communication could prevent many emergencies from worsening. As EMS professionals, our ability to remain clear, composed communicators is just as important as our clinical skills. By practicing these techniques, active listening, concise radio reports, respectful patient interaction, closed loop communication, and detailed handoffs, we enhance teamwork across all levels of emergency care. Ultimately, effective communication saves lives. Thank you for joining me, and let's all strive to communicate as true professionals on every call.